Good morning, everyone. So today I'll talk about chronic kidney disease and end-stage renal disease. And so we'll get started. Last talk was fluid electrolytes, and we've done other couple of other important topics before that. So we'll go to definition, then we'll discuss some. I have some questions which you guys can think about and try to answer as we go along. So, so chronic kidney disease. Uh, So the definition is irreversible loss of renal function and is characterized by at least one of the following, which includes structural or functional abnormalities in the kidneys and ultrasound, urine analysis, lab abnormalities, and irrespective of the GFR. So just make your attention to this slide is that for having a chronic kidney disease, it's not essential to have a decreased GFR. So you could have other things, as I said, either structural or functional abnormalities, any urine abnormalities, any sonogram abnormalities. So either of one of them will count as chronic kidney disease. And incidence is difficult to ascertain, but some people think it's around, end stage is around 1 to 2 per million. But CKD is very difficult because it's not, we don't do any sort of surveys to find out how many people have. So the first question is, CKD is divided into 5 stages based on, so think of one which you can think, I'm sure a lot of you might already know this, but these are sort of important topics and important things which probably would you want to know from CKD. So you divide into CKD depending on what? Serum creatinine, you estimated GFR based on formula like Short's formula, GFR determined by inulin clearance. And if you guys want to, give chat and send the answer, or you can tell me now or later, or serum cystatin. So any impression overall? If you guys on the screen, if I can hear you guys, anybody? You guys can hear me, right? Just want to make sure.
Yes.
Yes,
Okay,
we can hear you.
okay, because I heard there was a problem with Dr. Bambola. So anyway, so these are four thing, and you probably with the next slide you will know what it is. So these are stages of CKD. So National Kidney Foundation is something called National Kidney Foundation, and they divided chronic kidney disease into 5 stages. So stage 1 to 5, and as you can see, stage 5 is when you have the end stage where patients need dialysis, and then it goes from stage 1 to stage 5. As you can see, stage 1, the GFR is essentially normal. So GFR is more than 90. So if you want to remember CKD staging, you want to think about stage 5 first. So that's less than 15. 4 is 15 to 29. You can remember 15 to 30. Then stage 3 is 30 to 59 or 30 to 60. So after this one, it goes every 30, 30, it goes up. So stage 3 is 30 to 60, 60 to 90, and more than 90. So that's how the CKD is divided. And the formula we use for estimating GFR in children is what we call Short's formula. It's given in Harriet Lane. It's also available in a lot of other places. So this is the most common one used. This other formula by Conahan et al. But essentially you can remember only this one. So your creatinine clearance or estimated GFR, even for patients who we have on the floor, you should determine by 0.413 times height in centimeters divided by serum creatinine. So if you have 0.413, let's say patient height is 100 centimeters and patient creatinine is 0.41, what will be the GFR? 0.413 times 100 divided by 0.413. So the patient GFR will be 100 ml. So that's how you can use this formula and just put the numbers. You don't need even a you can do manually or just use calculator. So this is pretty much we use for all the patients, even without CKD, patients who come for other things. Just make sure you know that their essential or creatinine estimated GFR is normal before you give them medication. So some of them are nephrotoxic. So that's the answer of your first question is that the CKD is divided into different stages based on estimated GFR and it's called Short's formula. So what causes chronic kidney disease? There's so many things causes. So it's a chronic disorder, it's an irreversible disorder. So the most two common ones are either congenital malformation or nephritis. So congenital malformation including obstructive uropathy, they account 43%. Primary and secondary nephritis 26%. Interstitial nephritis related to drugs, some infections. Then hereditary nephritis, which is the most common one, is Alport's, and it's also very common. You can see 22%. And the miscellaneous causes include other types. Renal transplant is one of the causes of chronic kidney disease, and vascular causes like HUS. So the most common one, actually, what we see in our population is these two. So most of our patients have obstructive uropathy from posterior urethral walls. Some patients have reflux nephropathy. They also will come in this one, obstructive uropathy. And primary and secondary nephritis, most common one we see is FSGS and then also lupus nephritis. So all the patients we have on dialysis, at least for now, I think most of them, and one or two patients actually, we have one of Alport's hereditary nephritis. She just recently started on dialysis. So we have a mix of all of them actually. And obviously, patient who get a transplant, their GFR never kind of recovers back to completely normal. So some people consider them also as CKD, but that's called different. It's called renal transplant CKD. So these are the common causes. Just remember, what can cause to CKD. So how is that patients who develop, stage one, ultimately they go to stage two, and it is sort of an irreversible cycle. And once they get into CKD, the only thing you probably can do is try to prevent the progression, but you cannot really cure that time. So what's happening really? What's the pathophysiology that these patients ultimately, most of them will go into end stage. So what happens is that kidney consists of number of nephrons or glomeruli. Let's say you have renal injury on some of the nephrons. So a lot of them will die. So you'll have reduced number of nephrons. So essentially in the beginning, these nephrons, they try to overwork. So that means each individual nephron will have higher GFR compared to the one who don't work. And that will relate to local intraglomerular hypertension. And that intraglomerular hypertension ultimately leads to sort of a lot of release of cytokines, increased glomerular capillary pressure, and that ultimately leads to scarring. So this is a process, and again, same thing happening here. The renal injury, increased glomerular capillary hypertension, and it causes increased permeability to macromolecules, especially the proteins. So once you have this increased filtration of proteins, this protein itself, they're sort of nephrotoxic, and they cause scarring of the kidneys. And then from tubular reabsorption and secretion of TGF beta, you will see that kidney keeps on getting more and more scarring. So this is an irreversible cycle, which is difficult to kind of control. So what happens in CKD? So what's the big, why we talk about chronic kidney disease so much? So to understand chronic kidney disease, I guess you have to essentially know what kidney does normally to the body. So most people just think it's a fluid and electrolyte balance, and that's all. But as you can see, kidney is involved in much more other things than just fluid and electrolyte balance. So once you have CKD, we'll talk about one few of them one by one. Patients have growth failure, and we'll come to that why they have growth failure. There's something called renal osteodystrophy, anemia, metabolic acidosis. This probably pretty much, I think all of you know that when kidney has damage, you can get acidosis. And then obviously fluid electrolyte balance, which we talked before. Then hormone metabolism, a lot of hormones actually are excreted through the kidneys. So if there is a kidney problem, some of the hormones actually might go up because of decreased excretion. Then you get cardiovascular dysfunction. This can happen because of so many factors. There's something called endothelial dysfunction. Then you get hypertension, and also because of effects of uremia. So all these things affect the vasculature, affect the heart, and ultimately causes cardiovascular dysfunction. And neurological complication are much like less now, but patients who come in late stages who already had uremia for years, there's something called uremic, neurological neuropathy, which causes different dysfunction like nerve dysfunction. So, but in these stage, hopefully that if we diagnose them early, we should not be able to see this neurologic complications of CKD. So, first thing we start with the growth, because I think in children, the growth is most important for everything. So, kids with CKD may receive growth hormone for short stature because of, so think about one of the, what you think, guys, decreased secretion of growth hormone, insensitivity to growth hormone, both of the above, and none of the above.
Hmm. Which one do you think?
So, what are the factors involved in pathogenesis of growth failure? So, there are so many factors. One is the most two important ones are hormone imbalance and energy malnutrition. So, what happens? We'll talk about energy malnutrition first. Patients who have chronic kidney disease or ultimately severe CKD, they tend to have, first of all, they don't have appetite, so they might not be eating as well. They're also very hypermetabolic, so whatever they eat, that energy is not utilized as well. So this is usually the most common scenario in the beginning. But even if you fix, people saw that, then if you give them enough energy, put G tube in them, you give them enough calories, proteins, they still don't grow as well to the normal. So what they found was there's a defect in the hormone imbalance. So there's a defect in growth hormone IGF axis and hypothalamus pituitary thyroid disorder. So what happened? We'll talk about growth hormone axis. Then uremic toxins, they don't have, because of toxin, the growth hormone doesn't act as well. Renal osteodystrophy, we'll talk about that. And then the patients who have metabolic acidosis, you will see that you will also know that they don't grow as well. So what happened in this patient about the growth hormone? We were talking whether they have growth hormone less or they're insensitive. So let's see what's happening in their growth hormone. So typically, growth hormone is made by pituitary, and it works on the liver on the IGF receptor, and then IGF circulates in the circulation, binds to IGF binding protein, and that's how it ultimately acts on the bones. So what's happening to these patients? Is it less growth hormone, or there's a decreased receptor, or there's a decreased IGF for other reason? So anything could be happening. So what they have seen is that if you check their level of growth hormone, actually their growth hormone level is normal. So the growth hormone level is actually normal or even sometimes increased. But the issue one is that their receptor on the liver, tissue receptors, they are not very sensitive. So that's one issue. And other thing is that whatever IGF is secreted from the liver, it binds to IGF binding proteins, and that's how it circulates. So the effective IGF-1 is a free form. Whatever binds to IGF binding proteins is not active. So what happens, they think that IGF binding proteins might go up in these patients. So you have a decreased level of free IGF-1. So in some sense, that causes it doesn't work on the bone and patient don't grow as well. So most of these patients who have chronic kidney disease, we need to make sure that they're growing well and they're gaining proper weight. So, and they have done so many studies that pretty much growth hormone is a sort of standard therapy for patient with CKD. So as you give it patients who have decreased growth hormone level, uh, the way to do is that if there are less than 3 standard deviations or less than 99 percentile, and you have ruled out other causes of growth failure, you can start them on growth hormone therapy. But before you will check their bone age, you check, make sure their thyroid is normal, you check their fundus, that there is no increase intracranial tension, increase uh, intracranial hypertension. And then also you should do patients who might get near puberty, you should do Tanner staging. And then you start them on growth hormone therapy, 0.05 milligram per kg per day, and you monitor them. So a lot of these patients will take growth hormone for years. So basically, every 6 months to 1 year, keep charting their growth like you do in other patients. And then you monitor the height and weight. Once they're growing, you can also do adjust the dose, 0.05 milligram per kilo. And often then you would do IGF-1 check IGF-11. IGF-1 is for normal bone age. Once the bone age, let's say that they have all their epiphyses are fused, that's the point when growth hormone will not have any function. So you want to just make sure their bone, their epiphyses are open. You can do more mineral density, not very essential. And as I said, you should do Tanner staging, in the beginning and every year. So that was about the growth. So let's talk about a little bit about osteodystrophy, because these are few things which you will see more often in patients who have chronic kidney disease. So all of the following are components of renal osteodystrophy except, so all of them are components except, so which one you don't see? Hypocalcemia, hyperphosphatemia, secondary hyperparathyroidism, or hypercalcemia. So any,
Hypocalcemia.
say it again,
Hypocalcemia.
in osteodystrophy, which except
Hypocalcemia.
high, okay, let's talk about and we'll see. Because in patients who have CKD, hypocalcemia is very common, right? They come with actually hypocalcemia. They,
Hypercalcemia.
they don't develop hypercalcemia. They always have hyperphosphatemia. They have secondary hyperparathyroidism. I mean, we recently had a patient who presented basically with hypocalcemia, and we found that her BUN and creatinine was very high. So we'll explain the mechanism why they develop all these things. So why they develop hypocalcemia and hyperphosphatemia. So just a little physiology about calcium metabolism. 99% of body calcium is in the bones, and remainder is in the bound to serum proteins, complex with anions. 47% have free ionized calcium, so That's the one which is basically active form of vitamin D, calcium, and is regulated by vitamin D and PTH. So how does it happen? So let me see if I go to the next slide. So what happens in CKD and why they have decreased? So normally calcium, the absorption happens practically, most of it in the intestine. But for calcium to get absorbed, you need two things. You need vitamin D, and you also need sort of help from PTH. So what happens in these patients who have kidney problems? First of all, their vitamin D is not converted into the active form. So normally the active form is 125 dihydroxyvitamin D, and when the kidneys don't work, the vitamin D is not being hydroxylated. So that you don't have vitamin D, you don't absorb calcium from the gut. And also in the kidneys, typically kidneys excrete phosphorus. If you don't excrete phosphorus, what's going to happen is that your calcium will go down, phosphorus will go up. So that's the main two things which happen first in CKD. So decrease calcium and increase phosphorus or phosphate. So these are two essential things. But what will that do? Once the calcium goes down or PT or phosphorus goes up, it will stimulate your parathyroid hormone. And parathyroid hormone, what will that do? Is secreted from the parathyroid gland, and it goes to the bones and tries to uh, you know get calcium out of the bones, because calcium in the circulation is essential for body function. So when you have hypocalcemia, your PTH goes up, and it causes increased calcium um, absorption from the bones, and also tries to get excretion of phosphorus from the kidneys. So you will see essentially decreased calcium, increased phosphorus, and low PTH secretion, a high PTH secretion, I mean. So that's your essentials, but they never have hypercalcemia. So basically it's called renal rickets. If you compare that with the rickets which happens with the nutritional rickets, the only two things are different. In nutritional rickets, calcium is low, right? The way to remember calcium metabolism is, just remember it is a type of a rickets where they have decreased calcium. So in nutritional rickets, because there's decreased vitamin D intake, your calcium will be low, but your phosphorus will also be low, because kidneys really actually are able to excrete phosphorus. So you have decreased calcium, decreased phosphorus, and PTH is high. So hypocalcemia is actually a common factor in most of the rickets. And PTH is normally high. So phosphorus will distinguish renal rickets from nutritional rickets. So as we talked before, once you have parathyroid hormone in the kidneys, it will cause increased calcium resorption and increased phosphorus excretion into the tubule. It also causes the stimulation of 1-alpha hydroxylase, so cause activation of vitamin D. And from the bone, it stimulates osteoclastic bone reabsorption, so as to increase serum calcium. So net effect is increased serum calcium and decrease serum phosphorus. And so this is just, we're talking about hyporenal osteodystrophy. We need to talk about all these things because these are important. And when you treat them, you need to know what you're going to give them. So vitamin D, you can either take it, in the form of, you can take vitamin D. You can also get it from the skin, but ultimately it gets activated in the liver and the kidneys. And when you have CKD, right? So the vitamin D gets hydroxylated, one in the liver, and the next step is in the kidney. So if you use regular vitamin D, which is ergocalciferol or cholecalciferol, what will happen? You can hydroxylate in the liver, but in the kidneys you cannot hydroxylate. So essentially, the vitamin D, if you give only 20, ergocalciferol, it won't be effective in these patients. So you have to give them what we call renal form of calcitriol, or is basically 1,25 dihydroxy vitamin D. So in this patient, we need calcitriol. They're different names. Some of them are IV, some of them are PO, but these will need this type of vitamin D. So when you use vitamin D in this patient, use the activated form, not the ergocalciferol. And how much PTH you want to keep them in these patients? So typically, normal patients, the PTH level is around 45 up to 90. But patients who have CKD, your what you call PAH, PTH meter, you keep somewhere in about 150 to 300. That means you don't want more than 300, and you also don't want less than 150. So what's the reason you want to keep a little bit on the high side? The reason is that if you suppress PTH too much, what happens? The bones actually they don't get any stimulus from the PTH, and they really become adynamic. The term is called adynamic, and the literal sense is that basically those bones are not very active. They don't have, so sometimes we call it dead bones because there's no PTH. So you would want to keep them somewhere uh, PTH of 150 to 300 in these patients. These are things you don't have to remember all of them. But for us, when we treat patients in different stages, the calcium and phosphorus level which we want to keep is somewhere in this one. So stage 1, stage 3, essentially look at the PTH, you want to keep 35 to 70. Stage 4, you want to 70 to 110. And CKD stage 5, 150 to 300. So how do you treat these patients? Basically, you restrict this phosphorus because their phosphorus is high. You can give calcium supplementation to combat their hypocalcemia. And so calcium, if you give as a calcium carbonate, it actually works in two ways. It will increase your calcium. It also binds the phosphorus. So it acts in a dual way. So most of the time, all these patients are patients with CKD. They're receiving calcium carbonate. Only thing is if you want to give for just giving, increasing the calcium, you want to give in between the feeds. And if you want to bind the phosphorus, you want to give with the feeds. So a lot of our patients will get calcium carbonate with the feed or with the food and in between the food. And you can also use other phosphate binders, which is called sevelamer, or you can also, so which is a non-calcium binder. So, but a lot of times we just use calcium carbonate. So next we'll talk about a little bit about anemia, because of the few things which are almost present in all the patients who have CKD. So in CKD patient, the top two conditions that contribute to anemia are A, insufficient EPO and iron, insufficient EPO and inflammatory condition, if insufficient EPO and aluminum, and insufficient EPO and lead toxicity. So what do you guys think about this one? Can you read?
BB.
I think
Hello?
B,
Yeah.
B, insufficient
B?
echo and
Zero.
inflammatory.
Chronic, right?
Uh, okay, these are all important. What are the two more common ones? If you know any patient with the ESRD, typically what are they on?
They have
So aluminum used to be a problem some years ago, but not anymore. and lead is also not that big problem. So these two are more important.
Mm-hmm.
Obviously, inflammation contributes to anemia, but the most two important were EPO and iron. So if you had to answer in your board, this should be your answer, EPO
Iron.
and iron.
Okay.
So anemia of CKD, so we'll talk about that, what are the causes. This is EPO deficiency. And in the beginning, actually, the anemia is normocytic normochromic. If you asked, in your boards, untreated anemia, what would you normally see? So that's essentially is a normocytic normochromic. But once we know that when we start giving them EPO, they also need iron, right? So over the time, they will need both EPO and iron. The other factors are reduced RBC half-life. They also have sometimes decreased B12, decreased folate. Patients who have severe uremia, they have GI losses. And other things are which are less important is carnitine, growth hormone, and prednisone therapy also contributes. So there are a lot of contributors, but the most two important ones are erythropoietin and iron deficiency. So it's essentially your physiology that kidney basically makes erythropoietin. It can sense hypoxia or decreased blood flow, and it's made in the interstitial cell. And once you make erythropoietin, it gets circulated to the blood and in the bone marrow and acts on the progenitor cells and ultimately causes increased erythropoiesis. So essentially nowadays, if you had like few years ago, all these patients, they used to receive a lot of blood transfusion. But now because of erythropoietin, most of these patients really don't need any blood transfusion. So one is erythropoietin and then iron. So how do you treat this anemia? You give them erythropoietin. You can give IV versus subcutaneous. And subcu is 50 to 200 units per kilogram. And there's also nowadays, if you want to just give it during outpatient who are not on end stage, you can also give them, subcutaneous gervopoietin, which can be used actually only once a week, or sometimes even once in 2 weeks, because erythropoietin is a three times a week dosing. So that means 3 shots. With gervopoietin, you can only give one shot once a week, or even sometimes twice, every 2 weeks. So this is summary, and I think we have few slides about end stage, and then one second. So what would you want to do as a resident, or as a patient, somebody who takes care of these patients who has CKD? So first thing is that patients who you think are at increased risk, and which is kind of, with all this new incidence of obesity, hypertension, diabetes, you really want to make sure that they're not getting uh, that you checking their maybe microalbuminuria, you checking their creatinine. So in stage before that, even before stage 1, you want to see all the population which is at risk. So patients who are born as premature, they also at risk. As I said, obesity, hypertension, diabetes. Patients who are received other like type of bone marrow transplants, receiving other nephrotoxic medication. So these are all at risk of getting CKD. And then once they are in different stages, you want to make sure that their kidney disease doesn't progress as fast. Chani, can you one second, guys? So sorry. So stage 1 kidney disease, you have diagnose and treat. You try to slow their progression, and you try to decrease the cardiovascular risk factors. Again, stage 2, stage 3, everything will continue. You try to slow their progression, and stage 3. But once you're in stage 3 or late stage 2, You don't want to just keep on waiting till the stage 4 and stage 5 comes. And stage 4, you want to start getting ready and talking to them about the next stage, which probably will be something where would might need kidney transplantation, or they might need some type of renal replacement therapy. So let's say if they need dialysis, you want to start talking about fistula formation, because it'll be very, very sort of not a proper management. That patient has been seeing you for all the years, and then in the last stage, you have to tell them to go and get, emergency catheter formation to get to dialysis. So you want to get them ready. You need to tell them, that they can find some donors and what type of therapy they would need. They want hemodialysis, they want peritoneal dialysis. So in stage 4, you should be ready with all that. But once you come to stage 5, where GFR is less than 15, then they need some type of replacement therapy, either dialysis or a transplant. So coming to the last form of CKD or last stage, which essentially takes a lot of our time, is stage 5. So as you saw, that CKD stage 5 is when GFR is less than 15. And at that stage, as I said, if you look in the previous slide, they need some type of replacement, either dialysis or transplant. So we'll talk few things about actually mostly dialysis. So the ideal form of dialysis in children is hemoperitoneal, or depends on the patient and family situation. So obviously, I think you guys will answer the C, because there's nothing like which we can tell this is best for you. Depends on the patient condition, also family situation, but there are essentially two type of dialysis: hemodialysis and peritoneal dialysis. So we'll talk about these two a little bit. So end stage. Just quickly, just for otherwise for your people who ask sometimes, when do you do dialysis? So if you want to remember, just remember this A, E, I, O, U. So these are like indication, for your remembering for your boards, quick answering. So A is anorexia, hypoalbuminemia, acidosis. E is electrolyte imbalance, especially increased potassium. Intoxication means poisoning. O is salt and water overload, and U is uremic symptoms. So what are the goals of dialysis? So goals is basically remove the uremic toxin. You correct the secondary effect of uremia. You can replenish calcium and bicarbonate because they have acidotic. And you can remove excess water and salt. So dialysis is a process where a solute composition of a solution A is altered by exposing to solution B by exposing to semi-permeable membrane. So it happens by either by diffusion or by ultrafiltration. So diffusion is basically movement of solutes across a semi-permeable membrane, depending on the molecular weight, on the concentration, on the charge of the molecule, and also the resistance of the membrane. So that's what we use for when we do dialysis in patients, is that these are the principles we used. So ultrafiltration is movement of water. So solutes move by diffusion, water move by ultrafiltration or by osmosis. So ultrafiltration refers to movement of solvent, and what happens is that the water will move towards, in some sense, where the osmolarity is higher. So if there's two solution, one side is low osmolarity, other solution is high osmolarity, the water moves towards a higher osmolarity. And think of it as water moves towards salt or sugar. So wherever there's higher osmolarity, because of that, water will move towards that side. As I talked before, so this is your high water concentration on one side. You have on other side mostly sodium, chloride. There could also be sugar, let's say, dextrose. So water will move from higher water concentration to this side, which has more of solutes. So water is shown by all these red particles. So if you haven't seen hemo, I guess you most of might not have seen, or some of you did. That's how a typical dialysis in a place looks like. So what you have is basically this is the chairs, this is the dialysis machine, and these are the fluids which are being hanged. And so what's happening is the patient comes, and these are all the lines. So from the patient, blood comes out, goes into these tubes. Then you have here, I don't know if you can see, there's a dialyzer which is being, hung over here. That blood goes back, and basically you have done the hemodialysis. So this is showing how it happens. This is the uh, blood coming out. So this patient, if you have fistula, blood comes out, and a lot of times we need to also anticoagulate them. It goes into their kidney, what this is called dialyzer. We call it kidney for the patients, but basically it's a dialyzer. And then basically again, the blood goes back into the circulation. So that's how your dialysis works. This is hemodialysis. And the kidney I was trying to show you guys was, this is the dialyzer. As you can see, these dialyzers actually have a lot of these small capillary filters. And it's a, sort of a science, what they have done is they have made so many micro capillaries. And what happens in these capillaries, so this is how your blood goes in, comes out from here. But if you look at inside, if you open it, you will see all these capillaries, the blood flows in them, but outside you'll see what the dialysate flows out. So all you see, there's a little bit of yellow or greenish one. So blood flows in these capillaries, dialysate flows outside, and when you run the blood, what you will do, the blood has a lot of BUN, creatinine, potassium, and your dialysate fluid has very little of, there's nothing potassium in that. It also has bicarb. So what will happen is that BUN creatinine will move out of the blood and they will go into the dialysate fluid. And it keeps moving. So we run it for 3 to 4 hours. That means during that time, essentially every run which is going is removing BUN and creatinine and potassium. So that's basically sort of a simple way to explain how these dialyzer work. You don't have to know all this, but for other people, they're different type of membranes. But for now, I think just know that these membranes are basically biocompatible. And so typically nowadays we use polysulfone. I think you might not want to know that, but it's just to show you that the clearance will depend on the size of the molecules. Smaller molecule will have more clearance. So BUN creatinine is small. Phosphate is a bigger molecule, and B12 also is bigger. So their clearance is less than uh, the clearance of BUN and creatinine. So in nutshell, these are dialysate composition. Sodium is 135 to 145. Potassium is 0 to 4. Calcium is 2.5 to 3.5. Magnesium, chloride, and bicarbonate. And can you 1 second? Shall this is your blood flow inside. So this is how the catheter goes in, and blood comes out. So basically the catheter is sitting in the vasculature in the venous system. So, but this is the catheter. So these are two ends. One is what called arterial port, one is venous port. So you pull the blood out from one, push the blood out from the other one. So this is how the catheter will look like for hemodialysis. What complication can happen with hemodialysis? You can have acute or chronic. With acute dialysis, you can hypotension, cramps, nausea, vomiting. And with the chronic, you can see malnutrition. Patient will get hypertension, hyperlipidemia, pruritus. And so these are this complication you should know, because that's how you're going to decide which type of therapy you want to do. Just quickly, the one other complication I think which is not mentioned but is important is infection. So these catheters a lot of time will get infected. So when this catheter get infected, the infection goes into the circulation, and basically they develop, in some sense, sepsis or so. That's the most sort of serious complication. That's why the hemodialysis catheters are not really considered a good type of therapy. And quickly, 5 minutes on this peritoneal dialysis, then we'll be done. So remember we said which type therapy is best, peritoneal, hemo. But to decide, first of all, you need to know what it is. So what is peritoneal dialysis? In peritoneal dialysis, basically what you're doing is again, it is the fusion of solutes. So fluid and solute exchange between the peritoneal membrane and the capillaries, and the dialysate in the peritoneal cavity. And so dialysis membrane here is not the filter I showed you, but basically the peritoneal membrane acts as a dialyzer. So body, basically you're using natural bodies, what body gave you to do the dialysis. So this is a cartoon showing the peritoneum. So you have this capillary, which has endothelial cell. There's the bowel. There's a mesothelial cell on the peritoneum. So, and this peritoneal cavity. So what you would do in these patients is that you would put a fluid in this cavity, and there's a capillary which has a lot of potassium, again same way, a lot of creatinine. And what happens if you have dialysate fluid here? So there will be concentration gradient, right? So there is essentially there's no BUN creatinine in the PD fluid, no potassium. So potassium will move from higher concentration to lower concentration. Same with BUN and creatinine. So what happens over, like say, if you put the fluid for 1 or 2 hours, everything will move out, but then ultimately everything gets equilibrated. So what then after that, what you do is you take the fluid out and you keep on exchanging. So basically you're using your peritoneal membrane as a dialyzer. So what you do in this patient basically is that how it look like. This is your peritoneal cavity, spine and everything here. So peritoneum, as you know, that covers all this or organs inside the body. So essentially this is a space. So what you do is you put the peritoneal fluid into the PD cavity, keep it for a few hours, and then after that, once it's equilibrated, you take it out. Then you take in a new solution. So once you take it out, you fill another one. So basically you go through cycles of, fill and drain, fill and drain. And essentially you can do it by, you probably don't even need any, medical much help. Patients can do on their own. So this is called ambulatory peritoneal dialysis, that you let it go by gravity. They can just hang it and just put the fluid in. And adults can actually essentially do 2 to 3 cycles per day, and they're pretty okay with that. But in children, uh, let me just show this one. So the solutes will move by diffusion. And how do we move the water in these patients? So what happens is basically the PD fluid has concentration of dextrose and the 1.5 to 4.25 gram. And depending on the osmolarity, the water will move from inside the capillaries toward the peritoneal fluid. And you can change the water movement depending on the concentration of the dextrose. So as you can see, 4.25% dextrose has much more higher ultrafiltration. That means removal of fluid compared to 1.5. That's how the PD catheter look like. I show you the hemocatheter. So PD catheter, this end comes out. This is the end which goes inside the body and sits in the peritoneal cavity. So fluid will go in, sit in for some time, then you drain it out. Again, showing you again same thing. If you were here in downstate right now, we have one patient who's started PD 2 weeks ago. So that's is how this catheter is. This is your exit site. This is your peritoneal cavity, and you keep on basically filling and draining, filling and draining. That's how you do peritoneal dialysis. I'll just skip this one. And just to show you that PD doesn't have to be done manually. So this is what we call cycler. So what cycler basically does is that it takes care of all this run, in and out. So what basically you do is only you need to connect those PD catheter to the lines, and you hang all these bags. And so these are like, one bag. And you can, if you need more than one bag, you can hang other ones on the side. But essentially your machine will do all those cycles. So what you really do is in this machine, you can sort of punch in all the numbers you want, how much drain time, how much fill time, how many cycles you want to do, and how much total duration. So patients can actually do on their own. Patients or their families, let's say in their moms and parents can do it. So technically, in that sense, for PD, the patient doesn't have to come to the hospital and can be done by patient themselves. But only thing is it has to be done daily. Hemodialysis you can do 3 times a week, but PD you can do. PD has to be done daily, so you can't miss it. But good thing is that it can be done home, and patient doesn't have to come to the hospital. They just once a month they will come. We do their, labs for the monthly lab, what we call monthly labs. Check their BUN creatinine, check their hemoglobin, and if everything is okay, then they come next month. And the problem with PD is that uh, you can see they can still have complications. The catheters can get blocked, catheters can get malpositioned, the dialysate can leak, and they can also get infection. They can also get peritonitis, tunnel infection, or exit site infection. But as you can see, it's not a hemo, it's not a blood infection. So a lot of this infection actually can be treated at home itself. So if they are trained well, we can just tell them to how much antibiotic to put. And so in some sense, as you can see, PD is more gentle, it's more patient friendly. But only thing is that you have to look at the social situation, that there is somebody to do the PD at home. Especially for the kids, you need their parents to be able to learn and able to do the dialysis at home. So the advantages include it doesn't have hemodynamic effect because it's not going into the blood. It's more freedom, it's more stability, greater dietary. They can eat, what probably better than what they need on hemo. And if you need sometime medication, you can also give it by dialysis, but that's not the common route. But as you can see, essentially, it seems like a better dialysis for kids at least. What are disadvantages? It's gentle but less efficient. There's still a risk of infection. Patient, a lot of them get, start getting what we call patient burnout. They get tired. And if there's infection, the peritoneal membrane over the time will also become ineffective. So peritoneal membrane has its life, but most of the kids actually can do for years peritoneal dialysis. So that's for your PD. So I think basically your answer on that question should be, if you want to choose what type of dialysis, essentially the answer is depends on the patient situation. I think, yeah, that was my last slide, and we practically finish on time. Unless there's a question, anything? I can hear everybody. You guys can hear me.
Thank you, Dr. Mongia. This was a great lecture and a review for us. We really appreciate it.
Thank you.
Any last questions before we end the session?
No.
Okay.
Thank you, Dr. Mongia.
Thank you, guys.
Thank
Thank
you.
you.
Good luck.
Thank you.